Hi everyone, my name is Madeline Rowe. I'm currently pursuing the postgraduate diploma in health sciences, specialising in health informatics. And today I'll be talking about a clinical decision support system for acute ischemic stroke. Hope you enjoy. So what is ischemic stroke? It's a type of cerebrovascular disease, meaning it involves the brain and its blood vessels. It's the most common type of stroke, as greater than 80% of all strokes are this type of ischemic stroke. It's also a medical emergency, meaning that if a person has this, it's like a medical emergency, so they have to go to the hospital as soon as possible. What really happens in the body is that a blood clot or mass blocks a blood vessel leading to the brain, and this essentially deprives the oxygen of brain, and commonly it can be due to a fatty plaque buildup known as atherosclerosis. And if a person has stroke, they will present with these symptoms here. So it can include trouble speaking, sudden loss of vision, a loss of movement, particularly on one side, so the face, arm or leg, and a severe sudden headache. This sort of shows the links between it as a disorder and then linking it to its finding site, its associated morphology, and then again attributes. So this just goes into more details using the coding systems that we have. And again, this shows how it's linked all the way back to blood vessels, findings in the brain, disorder of the central nervous system, and then ischemic stroke itself could be with coma or without, and then all these other types. So why is this a problem, and what's the burden of ischemic stroke in New Zealand? It is the third leading cause of death in New Zealand. It is a major cause of disability in New Zealand adults, meaning that people live their life with this in disability. So it can have quite an effect, meaning sometimes people have to live with someone looking after them and helping them in their day-to-day lives. It is highly preventable, as we know what the symptoms are. There's also, we know about the risk factors. So old age, high blood pressure, obesity, high alcohol intake, and also reduced exercise can all be risk factors. And we also know that with well-coordinated acute care services in health, that we can actually prevent the outcomes from being worse than they need to be. In New Zealand, males have approximately 20% higher risk of this ischemic stroke than females. And time is brain, so that means the longer that these brain cells are without oxygen, the more damaged they will become. So we have this treatment called a blood clot busting, I suppose, medication, commonly called TPA, which essentially absorbs the blood clots and helps this stroke to subside and helps the person to recover, hopefully. But the thing about this treatment is that it has to be done within a certain time frame. If not, it's seen to be ineffective and not safe. Also, ethnic disparities do exist with ischemic stroke. In this way, Māori in New Zealand are more likely to suffer from ischemic stroke than non-Māori. So what is the treatment for acute ischemic stroke? So in New Zealand at the moment, in 2019, we follow this 2017 Australian clinical guidelines. And this replaces the New Zealand 2010 guidelines. And it includes several things as listed here. We'll go into detail into these later. And again, thrombolysis. The recent Cochrane collaboration study in 2017 has shown that it's effective, safe, and improves outcomes for people. So they're more likely to survive, they're more likely to be able to live independently eventually. And this is where TPA is given to patients, and they must satisfy inclusion criteria and exclusion criteria. And it also usually involves some sort of CT or MRI scan of the brain to rule out hemorrhaging, and must be given within a time window, and must be given in a well-equipped setting by trained staff who know what they're doing to give a patient thrombolysis. So we've already touched a little bit on why we should have a clinical decision support system for ischemic stroke. One of the big aspects of this is the quality improvement side. So in 2009, it was found that 3% of ischemic stroke patients were receiving thrombolysis, despite greater than 80% of all New Zealanders living where this treatment is available. So that suggests there's some potential barriers to this treatment, whether it be clinicians don't know how this procedure works, they don't know about it, but again, there's also systematic delays, such as in reaching the hospital, in triaging, and in delays to getting CT and MRI imaging, which are important in seeing if a patient is eligible for this treatment. And again, it's a medical emergency, meaning that this is a priority when someone comes in with symptoms of ischemic stroke. So it'd be really helpful to have some sort of clinical decision support to help clinicians make a decision for these patients. And due to the Cochrane collaboration showing thrombolysis as an effective and safe treatment, if in the correct setting and within 3 hours, it sort of suggests if we have the resources and we have the people who know how to do it, we just need some sort of support to further assure them as in the clinicians doing this thrombolysis, that it is the right treatment, as the clinical decision support system has indicated that it's a good decision to make for this patient. And again, for quality improvement, it can help door to needle time and door to CT, etc. So what I've done is I've made a mind map of the proposed acute ischemic stroke clinical decision support system. So I'll just show you in a little short video now how it will work. So first we've got our inputs, and these are as follows. So stroke patients are a medical emergency given high priority. So they have all these things occur in blood tests. Then we find their clinical and family history. We do carotid imaging. We note their sex and age. And then an urgent MRI or CT scan is required. We also do an electrocardiogram. And then often what we see is this facial droop or arm drift or speech issues in people with stroke. So the idea is that once a patient is in the ambulance, they do a pre-hospital stroke screening tool. They use one to note these things, and that further helps the ED when the patient arrives there. They don't have to do that screening. Then the users would be clinicians experienced in the evaluation of stroke. The outputs. So essentially, it would lead to a patient eligible for thrombolysis, means that thrombolysis would be given intravenous, TPA given within 4.5 hours of onset. And then this later on could lead to secondary prevention, including ongoing rehab and recovery, managing secondary complications. So again, these could be gone into more detail, but the main focus of this decision support system is to reach the decision of thrombolysis or not. So that just goes closer in. So the alternative would be no thrombolysis, so other treatment options. So what would the process, workflow, or models of stroke care in DHBs look like? So we would assume that stroke patients would be accessing the emergency services in their area, and that could look like any of these: a comprehensive stroke care unit, an acute stroke ward, a stroke rehabilitation unit, or a mixed rehabilitation ward. So that could end up being one of these that they end up in from here. And then this just goes back to the topic of acute ischemic stroke due to ischemia in the brain, in the cerebrovascular system. And that shows the whole map as a whole. So if I go back to my presentation, the overall objectives of this CDSS is to aid clinicians in making fast decisions for acute ischemic stroke and their treatment, and particularly to start thrombolysis if the patient is eligible. And in the long term, this leads to better patient outcomes, such as more likely to survive after a certain amount of days after having the stroke, and also more likely to live independently. Some limitations have been reflected upon, so every stroke case is unique, so there could be ways to encompass this into such a system to ensure that the right decision or alternative decision is being made for each individual patient. And like all technology and innovations, testing and implementing new systems is challenging, as is the uptake. And here's my references. So thank you for watching.